I want to welcome everybody to our educational program tonight, Breast Cancer Treatment Updates in Oncology, Surgery, and Radiation. For those of you who might not know me, I'm Stephanie Stern. I'm the Program Director here at Hope Connections for Cancer Support. And Hope Connections is a nonprofit organization dedicated to helping people who've been affected by a cancer diagnosis and their loved ones. We offer cancer-specific support groups, general cancer support groups, mind-body classes, and educational programs like this. So I'm really happy to see all of you here today and to have three wonderful doctors to present here with us tonight. And I'm going to introduce them, and then I'm going to turn it over to them. So I'm going to introduce Dr. Melissa Weifhaus first. And Dr. Weifhaus is a radiation oncology who uses radiation therapies to treat cancer. She's experienced in treating all types of cancers, but has particular interest in lung cancer, breast cancer, gynecologic cancer, gastrointestinal cancer, and sarcomas. She also specializes in palliative care radiation oncology. Dr. Weifhaus uses the latest technological advances to treat her patients, including proton therapy done at the Maryland Proton Treatment Center. She's dedicated to advancing the field of radiation oncology and is medical director of radiation oncology at the Cancer Center at the University of Maryland, Capital Region Health. She's also the chair of Diversity, Equity, and Inclusion Committee in the Department of Radiation Oncology at the University of Maryland, where she is an associate professor. And Dr. Katerina Ciapoli is a fellowship-trained breast surgeon and breast health expert. She has years of experience treating all types and stages of breast cancer in both women and men. She understands her patients and knows that treating breast cancer is about more than removing a breast or a tumor. Dr. Ciapoli performs procedures at the University of Maryland Capital Surgery Center and University of Maryland Laurel Medical Center. As the surgical treatment of breast cancer is constantly evolving, she and her team uses oncoplastic techniques to help preserve and even improve the appearance of the breast. And Dr. Nicholas DeMonico is a medical oncologist with Maryland Oncology Hematology and their Brandywine and New Lanham offices. He currently serves on the Pharmacy and Therapeutics Committee, monitoring the use of cancer drugs in the practice and evaluates new drugs as they are approved. One of Dr. DeMonico's primary interests is doctor-patient communication. During his fellowship, he participated in a dedicated program funded by the National Cancer Institute with the goal of helping oncologists in training improve their communication skills with patients who have a serious illness. And I just want to thank all three of you for being here with us tonight. And I'm going to turn it over to you.
Thank you, Stephanie, for all that you do for our patients and for putting together this event. I think everybody decided that I'm going to get started first. So give me 1 second while I share my screen. All right, so I wanted to give you an update on a couple of things that we have been discussing in the breast surgery world and how these apply to patients. I know we probably have seen a lot of the data that I'm going to show here, a lot of the statistics on breast cancer. It's towards the end of October, so we've all heard what's happening. And I'm sure most people have heard that breast cancer is one of the most common cancers that women face, and 1 in 8 women will develop breast cancer in their lifetime, which translates to about 13% lifetime risk. It is the second most common cause of cancer-related death in women, with lung cancer being first. These are some projected numbers for 2024. So by the end of this year, We expect to have upwards of 300,000 women with new invasive breast cancers and about 2,800 men. They get affected by breast cancer as well. And an extra 56,000 and or so women with non-invasive early stage breast cancer called DCIS. The number of women dying from breast cancer will end up being around 42,000. But just to put a positive spin at the end of this, these big numbers, over 4 million breast cancer survivors in the US at this point. So just to remind you that the majority of breast cancers present and are diagnosed at an early stage. So if you look at this pie chart, the dark green colors, which make up more than 90% of all cancers, are either localized to the breast or are in the breast and regional lymph nodes. The chance of having stage 4 disease or metastatic breast cancer right when a breast cancer diagnosis is made is very low. It's hovering around 6%. And this kind of shows us at the first two columns the excellent survival that we have with early stage breast cancer. So the earlier the stage, the better the prognosis. Once we get into the stage 4 disease, then the numbers become a little bit lower, but we're working towards that as well. And this is the two lines that you see. This is a graph that shows you what we call the incidence of breast cancer, how many breast cancers we see over the last few decades, and then the mortality, the chance of dying from breast cancer is the bottom line here. These kind of two areas here, this box you can see is a little off the chart, and that is what we had to deal with during the COVID era. So now we're seeing a little bit of an uptick in the diagnosis of breast cancer, sort of making up for all the lost screenings and opportunities for diagnosis that we had during COVID. The good news is that you see kind of here in this line, it keeps going down. So we see a steady decline in the mortality from breast cancer. So that is the great news, that the chance of dying from breast cancer is decreasing. And that has a lot to do with a lot of different factors. Early detection, as I showed you, plays a huge role. The earlier the stage, the better the prognosis. Better treatments, and I know Dr. DeMonico is going to talk a little bit about that. So the better treatments give us better results and outcomes. And also personalizing the treatment. We don't treat everybody the same as we used to even a few years ago. We try to tailor the treatment so that we give the treatment that is only necessary and is going to make a difference, and also save patients unnecessary side effects. I'm going to put in this plug, even though this is not a screening mammogram discussion. I'm going to just mention that mammograms save lives. And even though it's not the most comfortable experience in the world, once a year we should go ahead and get our mammograms. As I mentioned, we are working very hard to individualize care and tailor the treatment of breast cancer to the tumor and to the patient. And we don't think that one treatment fits all anymore. We try to individualize it as much as possible. When it comes to the breast surgery, that means usually, this day and age, de-escalation of surgical treatment. So we try to minimize the extent of surgery that we perform to decrease side effects and still give patients an excellent result. So I'll show you a couple of big areas where de-escalation is happening. One of them is the type of breast surgery. I'm sure if any of you has dealt with breast cancer, we always discuss I don't know why my room got so dark all of a sudden. I'm sorry about that. The light seems to be playing with me. But at any rate, we always talk about mastectomy versus breast conserving surgery or lumpectomy. So traditionally, we have talked to patients about mastectomy with lumpectomy having good results, being close as far as good results are concerned. And we always thought, oh, if we add the radiation to the lumpectomy, it comes close to the mastectomy. But we're getting more data in this area as the years go by. And now we know from multiple smaller studies and some bigger studies that breast conserving surgery overall is preferable. It leads to better outcomes. I put up here a very large meta-analysis. So when we talk about meta-analysis, it means that we collect a lot of different studies that are similar in design and goals, and we analyze them all together. So these researchers put together several studies with over 1.8 million patients from around the world. And these were patients with early stage breast cancer, and they looked at their survival. The study showed that patients who had breast conserving surgery had significantly better survival compared to patients who had mastectomy. So this is something that we need to keep in mind when we're talking about surgical treatment. Breast conserving surgery we prefer when possible because it's less extensive, the recovery is easier, and in the right hands, it gives patient excellent cosmetic result. It preserves the sensation to the breast. It disrupts the body image the least. And it also seems to be preserving the sexual function that the breasts contribute to. We actually have had now several studies where patients get to report how they feel about their breast surgeries. This is one study that I particularly like that I put up here because it used a validated tool that we have to evaluate the experience that patients have. And it showed that this compared patients who had lumpectomy and radiation versus patients who had mastectomy and reconstruction. And what it found is that patients were equally happy with how their breasts looked, the appearance of their breasts. But where the two categories were different was their psychosocial well-being and the sexual well-being. And that was significantly worse in women who had mastectomy and reconstruction. So even if the women liked the way their breasts looked, they did not fare equally well as far as their psychosocial well-being and sexual function. So again, something to keep in mind as we're making decisions and help our patients make decisions. So some of the things that we try to do is educate our patients. You know, when we first meet patients with a breast cancer diagnosis, the human reaction is just take them both off, just remove the breasts. And it's normal to think that, oh, if I have the breast removed, then overall I'm going to have a better outcome. It is less likely that the tumor will come back. So our role as surgeons is to sit down and talk to the patients and explain the data that we have and explain the facts and just to help them make an educated decision. Our role is also to expand who we can offer breast conserving surgery to. I know Stephanie mentioned oncoplastics techniques, which is something that we do either by ourselves or in collaboration with our plastic surgeons, and allow us to remove bigger portions of the breast and still reconstruct the breast afterwards and reshape it so that we give the patients a very good cosmetic result and still being able to do breast conserving surgery. We also use neoadjuvant treatment, meaning we use medical treatment upfront to shrink the tumor so that more patients are eligible to preserve their breasts. So after all that I've said, who needs a mastectomy? There's still indications for mastectomies. There are certain tumors that are very extensive and take up the majority of the breast. So in those cases, we cannot save the breast. There's also certain aggressive types of breast cancer, such as inflammatory breast cancer, where we don't have any information to de-escalate treatment, so those patients still require a mastectomy. And there's also some patients who have abnormal genetics, normal genetic mutations in their bodies that make it very risky for them to have more breast cancer. So those patients may benefit from having bilateral mastectomies. And the second area that I wanted to focus on is lymph node surgery. And I put over up here the one of the most dreaded complications of lymphatic surgery, which is lymphedema. And you see here different stages of lymphedema, from very mild to very obvious and debilitating lymphedema. So what we have been working as breast surgeons is de-escalating lymph node surgery, doing only the absolutely necessary surgery to avoid these negative effects. And it's not just lymphedema, extensive surgery and radiation. I'm going to include that as well, because radiation can cause lymphedema as well. Can also cause a lot of scarring under the arm, trouble moving the shoulder, decreased mobility. So those are all things to consider. So just putting up some anatomy pictures here. These are the lymph nodes that are under the arm and where the majority of the lymphatic drainage from the breast goes. And you see different groups here that we remove when we have to perform a larger surgery, which is called an axillary dissection. Over here, I'm showing you the technique, how we use the sentinel node biopsy technique. So that involves injecting some dyes. You see a radioactive dye here and a blue dye. And those dyes show us which lymph nodes are directly connecting with the breast. So we remove only those and not all of the lymph nodes. So this technique, the sentinel node biopsy, used for several decades now with excellent results. And that is the standard of care. So one of the campaigns that the Society of Surgical Oncology is using is called Choosing Wisely campaign, where it is stated that we do not routinely remove all the lymph nodes from the underarm for early stage breast cancer. And we also try to individualize treatment and be very thoughtful about the extent of surgery that we do to the lymph nodes. Another area that we have made significant efforts to decrease the lymph node surgery is when it comes to DCIS. So DCIS is a non-invasive cancer. So the chance of it spreading to the lymph nodes is very, very minimal. So there is no indication in removing lymph nodes for DCIS. Sometimes when we were removing the whole breast for DCIS, we would do the lymph node biopsy as a precaution, just in case something was found, and then we lose the opportunity to do the lymph node, the sentinel node biopsy. But we've even stepped back from that. We have a dye that we can inject in the breast before it is removed, and that marks the lymph nodes. So if we find something at the end, when the breast is examined, then we have the opportunity to go back and do the lymph node biopsy at the second surgery, although that is extremely unlikely. So again, we're trying to save the nodes and not take nodes that when it's not necessary. And then for early stage breast cancers that are, especially if they're estrogen and progesterone positive, and we have a clinically negative axilla, meaning we don't feel any enlarged lymph nodes and we don't see any enlarged lymph nodes on imaging, then we try to de-escalate the treatment. And depending on the patient's age, we may not even do any lymph node surgery. This is a machine that we are about very, very close to acquiring at our center. And if you see here on the right-hand side of the screen, this is a bioimpedance spectroscopy machine called SOZO. So you step on it just like you step on a scale, and you put your hands on the machine and the feet on the machine. And I'm going to be very simplistic about the description here as I understand it. Like an electric current goes through the body, and it measures different fluid and tissue density. So it basically gives us a graph as to whether there's any lymphedema in the body. So this is something that we use for screening after somebody has had lymph node surgery, and that applies to other parts of the body. I'm just talking about the breast, so I'm thinking of the R, but for patients who have had lymph nodes from their pelvis or groins, that can apply to the legs as well. And that detects lymphedema before we are able to see it or detect it with other methods. So it detects what we call either early stage or subclinical lymphedema. And there's been some studies that showed that if we intervene at that point, then we are able to stop lymphedema from progressing. So that is huge. And I'm just going to keep going and show you a couple of different techniques that we apply in surgery. This is axillary reverse mapping, where we inject a dye in the arm and try to find the lymphatics and lymph nodes that drain the arm and preserve them, leave them out of our surgical field so that we don't interfere with the lymphatic drainage of the arm, and that causes much less lymphedema. And also we have techniques where we can sort of reroute the lymphatic drainage of the arm after we know where it is. We can plug these lymphatic vessels into a vein and create a new drainage pattern for the lymph nodes, so that decreases the risk of lymphedema. And here I'm showing you another technique. This is a few lymph nodes that were harvested from another part of the body and are transplanted into the arm. And that creates another path for the lymphedema to drain. So that decreases that surgical treatment of lymphedema. I think that's all I had. I can talk about this for a long time, so I'm sorry if I went over, but I'm sure we'll do questions at the end or now, whichever you guys prefer.
Maybe we'll save our questions till the end, if that's okay. But thank you so much. This was so informative.
Thank you.
Hey, I think I'm next. So again, my name is Nick DeMonico. I'm a medical oncologist, and I've been working in PG County for MOH in our practice since 2006. And my training is focused on using medication for cancer patients. And today we'll talk about, how do we think about using medication for breast cancer patients? One of the things that you saw at the beginning of Katarina's talk is that there's a small number of patients with breast cancer who have advanced disease when the breast cancer is found. It's only about 6%. And for those patients, surgery is not really used. The mainstay of treatment we have for those patients is medication. And so when you give someone medication, it goes to all different parts of the body and it treats the cancer wherever the cancer may be. But the majority of patients are diagnosed with breast cancer when the breast cancer is found early. And most of those patients still get some medication for their breast cancer. A lot of patients ask me, well, if the surgeon removed all the cancer, why do we have to do this medication? Well, the reason is there could be some tiny microscopic cancer cells that are left behind after the surgery, things that are too small to see on x-rays and too small for the surgeon to feel with their fingers. And we know from well-done studies with thousands of women that if we use different medications after surgery, we can treat those microscopic cancer cells and we can lower the risk of the cancer coming back in the future. So what are the medications that we use? Well, we base our decisions on medications on information that we get from the breast cancer tissue. This is stuff on the path report, sometimes from the biopsy or sometimes from the surgery. About 2/3 of patients with breast cancer test positive for the hormone receptors, the estrogen receptor and the progesterone receptor. And we know that the estrogen in the body can, quote unquote, feed the breast cancer cells or stimulate them. So we have a lot of medications that we can use in the hormone category that can treat women who have estrogen receptor positive tumor. And that's a nice benefit because most of the time, the medication that is hormone based is really just a pill that someone can take. And so that can have fewer side effects than some of the other medications that we deal with. About 20% of the patients that we diagnose with breast cancer are positive for a marker on the cancer cell called the HER2 marker. And the reason why that's important is we have medication that's been developed to sort of attack that marker on the surface of the cancer cells and help to kill the cancer. So Herceptin is the common medication, and there's other medications that are in that category. About 10 to 15% of breast cancer patients are negative for the hormone receptors and negative for the HER2 marker. So we call those patients triple negative. And the treatment that we have available for triple negative patients is chemotherapy. Now, we frequently use chemotherapy in the other groups also, but for patients with triple negative disease, when we're talking about medication, we're mainly talking about chemotherapy. So what is chemotherapy? The word is really not that specific, but generally when we talk about chemotherapy, we're talking about medications that work to kill fast-growing cells. And so we know that the cancer cells are growing without the usual control mechanisms in the body. They're growing more quickly than the other cells. And so chemotherapy is usually medication that can get in the cell and sort of mess up the cell division process for the fast-growing cells. The other thing about the cancer cells, because they're not normal, they don't have the usual repair mechanisms to recover from an insult. For example, like after you get a sunburn, your skin's going to recover from that because your body's going to take care of it. The cancer cells aren't able to recover as well. So that's how the chemotherapy can work to kill the cancer cells. The problem is the chemotherapy is not that selective. It can also cause issues with other fast-growing cells in the body, even normal cells. So I spend a lot of my time talking and managing the side effects of chemotherapy. So I wanted to go through what are sort of some of the common or the most significant side effects of chemotherapy. Hair loss happens with a lot of chemotherapy drugs, not all of them. The hair follicles are the fast-growing cells. So when the chemotherapy affects the hair follicles, then patients on chemotherapy will get hair loss. Your hair will typically grow back after the chemotherapy treatment. It may not be exactly the same as it was before. There are some products out on the market called cold cap treatments. So you might have seen or heard about those, and there's different companies that make these products. It's like a hat or a helmet that really puts, it's like an ice pack on your scalp, or sometimes it circulates cold fluid through the scalp. What that does, because the chemo is in the bloodstream, it constricts the blood vessels to the scalp. We don't need the chemotherapy to go to the scalp. We need the chemo to go to the rest of your body. And if we constrict the blood vessels and there's less blood flow to the scalp, there's less medicine delivered to the scalp. And so some patients can use the cold cap therapy and not lose their hair. Notice I said some patients, because it doesn't work for everybody. It's not a guarantee. And one of the issues with the cold cap treatments, one of the problems is it is not yet covered by insurance. So there's a cost to doing a lot of the cold cap treatments that sometimes is just not practical. Next, as far as side effects go, nausea and vomiting can happen with chemotherapy. In the year 2024, we actually have really good medicine for preventing nausea and vomiting. So it's pretty rare now that patients getting chemotherapy struggle a lot with nausea and vomiting. We give patients anti-nausea medicine ahead of their chemo, so it's in the system already. And then we give them medicine that they can take at home in case they feel any nausea. And if the first treatment plan is not effective, you can usually add more nausea medicine. So that's something that we can control pretty well. Another side effect that we see with a lot of chemotherapy drugs is the chemo will lower the blood counts. And when the chemotherapy lowers the white blood cells, there's an increased risk of infection. And so a typical schedule would be where you might get chemotherapy, and then 3 to 5 days later, your white cells would be low, and the white cells might stay low for 4 to 5 days. And so we have some medications in an injection form to help build up the white blood cells. But if your body can't fight off the infection, you could end up with an infection, and we would send patients to the hospital. The chance of that happening during most chemotherapy regimens is probably about 10%. So it's something that's serious. It's something that we talk about. It's something that we're always careful about. But I always reassure my patients that the chance of that actually happening is really not that high. I saw a question in the chat about the cold cap, and it's a good question. They've done studies that there's no clear increased risk of a cancer or decreased effect of the chemotherapy for patients who are using the cold cap treatment. So it helps some patients keep their hair, and there's not a negative effect on the cancer. It's not comfortable. I'll tell you that from talking with my patients, because you have to wear the cold cap for the duration of the chemo. You don't wear it on the days that you're not getting treatment. But you may have that cold cap on for several hours, and one of the listed side effects is headaches, just because it's uncomfortable to have that cold cap on. The next side effect that we talk about a lot is neuropathy, or another word for that is just nerve damage. And so sometimes the chemotherapy can affect the nerves in the body. And the most common thing is numbness and tingling, but that can, if it gets worse, it can actually come with pain. And it affects the feet, and it affects the hands more than other parts of the body, because if you think about it, that's the most length of the nerve. So the nerves that are starting here and going down the spine go down your arm and go down your leg. And so you can have nerve damage that can affect your hands, your hands and your feet. Some people get mild neuropathy. There's just some numbness and tingling and doesn't really stop them from doing much. Um, Sometimes it can come with pain. Sometimes people with bad neuropathy on their feet are unsteady when they walk, and they might have to use a cane, or they might be at a risk for falling. Some people with neuropathy in their hands might find it hard to do certain movements like sign their checks or hold a cup of coffee. Um, the problem with neuropathy is that once the person has neuropathy, it's really hard for us to treat. We just don't have a great medicine that we can prescribe that makes the neuropathy go away. A lot of times, if you go through a course of chemo, the neuropathy will get better when the chemo is finished. It may take about 4 months for someone to notice if the neuropathy gets better, and it may not completely go away. You may say, yeah, it's not as bad as it was before, but you may always have some neuropathy. So what we have to do to manage that is check on patients closely during their treatments. And sometimes what we do is we make a dose reduction in their chemotherapy. Sometimes we give patient a delay of a week with their chemotherapy, and we do that infrequently. But of course, we don't want to change the schedule too much, because then we're concerned that we might be not following the right protocol for treating the cancer. So we have to be careful. We don't want to cause problems with that. So we try to manage that to prevent. There is a product that's out on the market where, similar to the cold caps on the scalp, you can have cold packs on your hands and on your feet. And the nice thing about that is pretty cheap. It's about $40 on Amazon. And you put the cold packs in the freezer before your treatment, and you have these little mittens where you have the cold packs on the front and back of your hands and your feet. I have not seen data proving that this really decreases the neuropathy, but just from talking with some of my patients who've used it, I have the general impression that it does seem to help. So if it's not too uncomfortable to have the cold packs on, I encourage patients to use those for prevention, because prevention is really the most important thing that we can do for the neuropathy. One other thing that I talk about with chemotherapy is just tiredness. We don't have a good pill for that. That just kind of comes with the territory. Different chemotherapy drugs cause tiredness to different degrees. The nice thing about the tiredness is it's typically predictable. So if someone's on chemotherapy once every 3 weeks, then what you might notice is that the first week is pretty rough with tiredness. Patients shouldn't be so tired that they can't walk to the kitchen and get themselves something to eat or walk to the bathroom. But that first week after chemo, most people are not feeling like going to Home Depot to pick up stuff for the house, or carrying bags of groceries in and out. So the first week, most people are really taking it easy. The second week, people are starting to feel a little better with their strength. And then a lot of times, if you're on a 3-week schedule, a lot of people actually feel pretty good for the third week. And then it's time to come back and do another treatment. So there's a long list of side effects, but I wanted to sort of highlight what we talked about the most. I think what really impacts patients the most with the chemotherapy treatment. And I think I saw a couple questions. So there are oral chemotherapy drugs that we use in breast cancer. There are other oral chemotherapy drugs that are out there, but I'm gonna, for tonight, I'm gonna talk about the ones that are available for breast cancer. There is a common one that's been available for a while called capecitabine. Um, then that can sometimes cause diarrhea, sometimes cause tiredness. It doesn't usually cause major problems with low blood counts. But there's a pill that we use for breast cancer. The name, I said the name, it's capecitabine. It also has this unique side effect where it can give you dry, cracked hands on your skin, dry, cracked skin on your hands and on your feet. But we have some medication that we can use to help with that. Now, separate from that, there's another class of drugs that I sort of think of as a lighter form of chemotherapy that are being used. They came to market for people with advanced disease, but now we're using them for some women after surgery. And this is Ibrance and Verzenio and Kisqali. And Verzenio, I know, has a lot of commercials on TV. And so the Verzenio sometimes has issues with diarrhea. But this whole class of medicine can cause low blood counts, not as bad as a lot of the IV chemotherapy treatments. So, and then tiredness is another side effect that can happen when we add those oral chemotherapy drugs. Now, someone had asked about cold packs for finger pain and hand pain and stiffness from letrozole or other aromatase inhibitors. I would tell a patient to do what works for you. The studies that were done talking about joint pains with the aromatase inhibitors, it can be worse when a person first gets on those medicines, and after you've been on it for about 3 months, it can get better. And physical activity is one of the things that can also help with the pain. So I would say if you're having pain and stiffness with one of the aromatase inhibitors, try your best to stay active. And I think certainly use cold packs if the cold packs are going to help. But I think activity and potentially tell patients to use Tylenol. If you're a patient that's able to take NSAID drugs, ibuprofen can help also. So those are the things we usually talk about. And then one of the things to talk about with neuropathy, I see the other question. Someone asked if someone gets bad neuropathy, will it go back to normal? And the answer to that is it's hard to say. Every patient's different. What I would tell somebody, if it's only 2 months after you finished your chemotherapy treatment, give it some time, because it's frustrating. It's really can affect your life. But over time, some people just notice that the neuropathy gets better. If it's been a couple years since you finished your chemotherapy and you're still having neuropathy, some of the neuropathy may not go away. Now, what I also tell people is just because the neuropathy doesn't go away, I have had some patients where we send them to physical therapy and they learn to manage better with the neuropathy. So it's not so much that someone's foot numbness totally gets better, but I have had patients go to like a really good physical therapist and get some exercises and notice that they're walking a lot better and they can do more things. So it's sort of trying to manage those things. Now, one other type of medicine, just as we're going through the different medication types that we have, is called immunotherapy. And that's another medication type which we typically use in the triple negative breast cancer setting. And what we know is that cancer cells have found ways to avoid the body's immune system. They almost have like a protective coating around the cancer cells. And there are medications like pembrolizumab or Keytruda where we can add that to chemotherapy, where we know that chemotherapy has a certain response rate, and we can increase the response rate if we add immunotherapy. In general, the immunotherapy doesn't add as much toxicity, not nearly as much as the traditional chemo drugs, but it has its own unique side effects. The immunotherapy can kind of ramp up the body's immune system. Sometimes people can get joint pain. Sometimes people can get a skin rash. Sometimes people can get something like a diarrhea type situation. But most people, we can add it. If someone meets the criteria, we can add immunotherapy in that setting and don't usually see the side effects a lot more. Now, one of the things to go over about how we use these medications, but there's a word we use called adjuvant. So most patients with breast cancer are going to have their surgery, and then we look at all the reports and we see what medications might help lower the risk of the cancer coming back. And so we would give those medications in the adjuvant setting. That's just a term that we use. And if someone is sensitive to hormones, they would get the hormone medications. If someone's triple negative, they would get the chemotherapy, perhaps with immunotherapy. We are now smarter than we were 10 years ago about who gets chemotherapy. And so we have special tests that we can order on the breast cancer specimen. Sometimes we do it on the biopsy. Sometimes we do it on the surgical specimen. The names of these tests are Oncotype or MammaPrint. And years ago, 15, 20 years ago, they kind of lumped a lot of breast cancer patients together, and we didn't have so much of a personal treatment plan. And we had high cure rates for breast cancer, but we gave a lot of women chemotherapy. And what we found out is that we can do special DNA testing to look at a DNA signature of the breast cancer, and it can tell us if someone is a higher risk for the breast cancer to come back or a lower risk of the breast cancer to come back. And that can guide us, and it allows a lot of women to avoid chemotherapy. So when I say we're smarter, what I mean is we're still able to achieve those very high cure rates. But we are treating fewer women with the more harsh chemotherapy drugs than we were 10 or 15 years ago. And so I think that's that's one big advancement that we have. I'm going to talk about one more thing that's an advancement, and then we'll move on to Mel. There's another. So we would add medication after surgery, and we would call that adjuvant treatment. One of the things that we're doing now, if we know that someone's going to be a candidate for chemotherapy because they're going to really need the chemotherapy to get to the highest cure rates, sometimes we give them chemotherapy before the surgery. And that has some benefits. Number one, you heard Dr. Ciopoli say that sometimes when someone gets their chemotherapy treatment before surgery, it leads to an easier surgery. Sometimes she can perform a less aggressive surgery, especially if someone has a very good response to the medication. The other thing that is really a benefit is when that person gets to surgery, we can analyze the breast tissue and see what kind of response they had. And if someone had an excellent response, it can be very reassuring to the patient. And we can reassure them that, their risk of their breast cancer coming back is fairly low. And if someone did not have a good response, that's somebody that we can push on to potentially do more treatment to still make their outcomes better. And so we call that neoadjuvant, because that's been one of the trends for people we know are going to be chemotherapy patients. A lot of times we're giving it before surgery. And then I saw one last thing in the chat, and then I'll hand it to Mel. So I have tried to be very cautious. There's a question about immunotherapy in patients with autoimmune disease. And so I have not typically used immunotherapy in patients who have any real active autoimmune disease. I think one of the things of, potentially why that may not have come up too much for me with breast cancer is because we use immunotherapy in the triple negative group. And the triple negative group is only about 10 or 15% of patients. But if I had someone with active lupus, I might send them to go get a consultation from someone who uses these drugs in those patients, because we do want to give someone the best cancer treatment, but we don't want to make their other medical problems worse. And so that's sometimes a tough situation to know what's the right thing to do.
Thank you.
Sure.
All right. Good evening, everyone. Thank you, Nick. And Dr. Siapoli. I'm going to, as in the real world, radiation is usually the last thing that breast cancer patients do get. So I'm going to share my screen, and I'm going to efficiently go through my slides so we can have time for discussion and questions at the end. Can you see my slides okay?
Yes.
Okay.
Yep.
Fantastic. So I, as some of y'all may have heard in the news or in social media, and I bring this up because I've had a number of patients and patients' families come to me and ask me about this. Younger generations, and my generation especially, I was born in '83, so I'm a millennial. We're at higher risk of developing cancers compared to older generations. And this was a study that was published just earlier this year in The Lancet. And I'm not going to go into details about this study for sake of time. However, what they did was they obtained incidence and mortality rates over 34 different types of cancers. And and through various cancer registries, they did individuals from the age 25 to 84 over a period of 20 years in the US. And in this figure here, what you see is a ratio of incidence and mortality compared to patients that were born in the 1930s, for example, and everyone else sort of born afterwards. And then you see that there's an increase of incidence and mortality rates, and this is specifically showing hormone receptive positive breast cancer compared to this 1930 cohort. So for some reason, we have a higher incidence and higher mortality rate of estrogen receptor positive breast cancer in later generations compared to older generations. And the reason behind this trend is very complicated and multifactorial, but there's been a number of data, a number of studies pointing to our diet and nutrition in the US. So there are at least 13 different cancers associated with suboptimal diet and obesity, and one of them being hormone positive estrogen receptor breast cancer. So this goes a bit beyond the topic of our conversation today, but this is also why, in part, we are starting cancer screenings much earlier. For example, for colorectal cancer a couple years ago, we're starting colonoscopies at the age of 45. I'm not going to be surprised if that drops to the age of 40 in the next couple of years. For breast cancer, we had an update earlier this year from the United States Preventive Task Force that women that are average risk for developing breast cancer should start their yearly screening mammograms at the age of 40 now. Whereas it used to be sort of like a cautionary sort of recommendation before. So, and Dr. Siapoli already spoke about this briefly, but each year the American Cancer Society, they estimate number of cases and outcomes of specific cancers for the year. In the state of Maryland, we're expecting about 6,000 new cases for 2024 alone. And like Dr. Seapoli mentioned, the majority of women, we are diagnosed at an earlier stage 1 localized disease, and that corresponds with excellent outcomes in overall survival. But I do want to note, and this is something that we see in Maryland, particularly in the county that we serve in Prince George's County, there is an inequity that we see between races. So Black women, for example, we're less likely to be diagnosed with early stage disease, more likely to be diagnosed with advanced regional disease, and that corresponds to a detriment in overall survival. Again, this goes beyond the scope of my talk, but I do want you to know this is something that we are aware of and something that we're trying to bridge the gap in at the University of Maryland. And a lot of my research involves identifying these inequities and trying to come up with practical clinical solutions to address them. And so for this talk, I will be focusing on some common themes, okay? How can we make radiation therapy more convenient for patients that need it? And in which patients can we safely omit radiation? And with that being said, for this particular section, we are typically focusing on patients that have small, early stage 1 breast cancers that are predominantly hormone positive and are not considered quote unquote aggressive. And so in general, for women who elect to preserve their breasts, like Dr. Seapoli mentioned earlier, and undergo a lumpectomy or a partial mastectomy, radiation is usually considered to decrease the risk of the cancer coming back or decrease the risk of local recurrence. And this can come in many different ways and forms. A few years ago, ASTRO, which is our National Radiation Oncology Society, they put forth some guidelines for women who are suitable candidates for partial breast irradiation, where we don't treat their entire breast, but we just treat where the tumor was, the lumpectomy cavity plus a margin. And there are different ways that we can do this, but for the most part, most common ways with a regular radiation machine called a linear accelerator, which we have at our cancer center at Cap Region Hospital. But in general, for most women who are suitable for partial breast irradiation, where we just treat where the tumor was, are women over the age of 50 with small cancers, usually less than 2 centimeters, invasive ductal carcinoma that is low grade with good negative margins, and of course with no lymph nodes involved with their cancer. And one of the ways we can deliver partial breast irradiation is through a machine that we have at the University of Maryland called a gamma pod. So we have this at the University of Maryland, not in our cancer center at Largo, but located in our Baltimore at our main campus. So patients are fitted, I don't know if you can see my mouse, but patients are fitted for their appropriate cup size, and they're connected to a machine that provides light suction. And what this does, this immobilizes the breast, and it doesn't move at all in this device. And we can deliver, and the patients will climb up to this device here, and they are actually on their bellies when they get treatment. And what this does, it immobilizes the breast in such a way that we can deliver high doses of radiation with a very, very tiny margin. And typically these partial breast irradiation treatment paradigms can be finished within 1 week of therapy. The gamma pod does use this sort of multi-source cobalt-60 system. I'm not going to go into the physics of it all, but just know that we have about 36 rotating beams that can really target that lumpectomy cavity plus a really small margin. This is an FDA-approved device, but it's only for early stage 1 breast cancers. So not all women are good candidates for partial breast irradiation where we just treat part of the breast. So we can also treat the entire breast using a linear accelerator, the machine. It used to be that radiation treatments were 6 weeks, given Monday through Friday, once a day of therapy. When I started residency, we had about 3 or 4 clinical trials showing that we can safely deliver that 6 weeks of treatment into 3 weeks. Now we have data, this was published towards the beginning of the pandemic in 2020. Now we have data saying that we can safely do it in just 5 treatments. So this was a study that was published, like I said, 4 years ago in women that had mainly low-grade hormone-positive breast cancer that was small. And on average, women were about 61 years old. And I don't know if you can see in this graph here, but on this axis right here, the y-axis, this is tumor recurrence. Look how low it is. It's 3%, right? Over a period of like less than 10 years. So this is a very very low grade or very favorable group of women who have a very low risk of cancer coming back after radiation. And as you can see here, these lines basically overlap. So in women that had 3 weeks of treatment versus 5 days of treatment, it was the same outcomes. And so we use this in select patients to go through radiation treatment very quickly and with very minimal toxicity, to be honest. Just some fatigue towards the end of that week and maybe some skin irritation similar to a sunburn, but women tolerate this treatment very, very well. And so so as Dr. Ciapoli mentioned earlier, most women with early stage breast cancer, the overall survival outcomes are absolutely excellent for most women. So we are probably over-treating a lot of women with treatment. And so one of the questions that we ask, do all women need radiation after a breast conservation surgery like a lipectomy? And there are some women we can probably safely observe and not give radiation to. These women are typically a bit older, over the age of 65, with small tumors, hormone positive. There's a theme here with low-grade cancer. And most importantly, they have to be taken an aromatase inhibitor, like Dr. DeMonico said briefly, medications that drop the amount of systemic estrogen in the body. But even with all of these favorable features, there is still a numerical benefit to radiation. So this was a study that was published, is updated, was published just last year. So PRIME2 was a study that was initially published over 7 years ago. And what it was a study where women, again, over the age of 65 with small hormone positive tumors, they flipped a coin. Some women, half of the women got radiation after their surgery, the other half did not get radiation. And the majority of women, actually all of the women, were on the anti-estrogen medication, the aromatase inhibitor. And what we found, and this is the update that was just published last year, that at 10 years, if women that did not get radiation, the risk of the cancer coming back was 10%. With radiation, it was basically less than 1. It was like 0.8%, 0.9%. So even though the benefit is numerically low, there still is a benefit. And these are the numbers that I share with patients, right, that fit this criteria. And I'm going to be honest with you, most women elect to do radiation, especially now that we can give it in such a short amount of time, in just 5 days, 5 treatments with very minimal toxicity. But I think the question is, what can we do? Is there a way that we can identify women where that benefit of radiation is 0%? And that's where a lot of clinical trials are going to right now. There've been a couple of clinical trials, including this one called the Deborah trial, using cancer genomic information to see if we can better identify patients who really don't need radiation at all, where that benefit is 0%. And in this trial, we're actually enrolling, this is a trial that we have open at University of Maryland as well. We're actually enrolling women who are younger, either 50 or greater. So we're trying to see if we can expand the age of women where maybe radiation therapy isn't helpful if they have early stage favorable disease. And so I just have a few more slides, left. These are some studies that are hot off the presses and dealing with women that have more advanced node-positive breast cancer. Dr. Ciapoli did show us some slides, some pictures about the anatomy there. But in general, patients with breast cancer involving their lymph nodes typically need radiation to not just the breast and the chest wall, but the surrounding lymph node or nodal areas as well. But even in women with breast cancer that is more advanced, we are still trying to make treatments more efficient, convenient, and there may be a group of women who may not need radiation to those nodal areas at all. And that's like the new area, exciting new area of research that we have more information on now. So this was a study that was actually just presented at our national meeting earlier this month. This was a study to see if we can safely deliver 3 weeks of radiation to that large target area, the breast, the chest wall, and the nodal areas, to women who need to have their lymph nodes irradiated compared to 5 weeks of treatment. Now, we have prior data from older studies to support that 3 weeks of radiation is just as good as 5 weeks in terms of controlling the cancer. However, we did not know if 3 weeks of radiation was non-inferior to 5 weeks in terms of cosmesis or surgical complications in women who had reconstructive surgery, okay, after their oncologic surgery. And to make a long story short, we now have this data to show that 3 weeks of radiation is safe and it doesn't increase the complication rates post-surgery after their reconstructive surgery. So about 900 patients, and this was a young cohort of women, 49 years old, median age of this cohort. And the majority of them got, as Dr. DeMonico talked about earlier, they got neoadjuvant chemotherapy. And these are the type of reconstructions that they received. And what we found is that 2 years after surgery, when we compared 3 weeks of radiation to 5 weeks, the rates of complications were no different between the two. So we now have data saying that, hey, in most women, we can decrease the radiation from 5 weeks, even if we have to treat a much larger area, to 3 weeks, and that does not affect cosmesis or surgical outcomes. So this is something that was just talked about at our national meeting just a couple of weeks ago, actually. Another area of research, do all women with node-positive disease need radiation therapy to their lymph node areas? We know that radiation to these areas can increase the risk, like Dr. Siapley mentioned, of shoulder joint dysfunction, lymphedema, and in left-sided cancers can increase the dose of radiation to the heart, okay? And we know that radiation to the heart can increase the risk of cardiovascular events like heart attacks and strokes. So it would be beneficial to identify women who may not need radiation to such a large area. So there was data published over 10 years ago now, and I'm not going to go into details of this graph of these different charts, but this is just showing that women that have node-positive disease, they got their chemotherapy, they did not undergo radiation after finished their chemotherapy. And what they found is that women who had an excellent response to chemo, meaning no cancer left in their lymph node areas, their risk of developing cancer down the road was less than 10%. So this is maybe, and if women who still have disease in those lymph node areas, that risk was much higher. So we could potentially target women who may not need radiation to such a large area if they have a great response to chemotherapy. And so this was a study that sort of preliminary data sort of fueled this randomized trial, NSABP B51. And essentially, it just targeted women that had node-positive disease to begin with. They got their chemotherapy. If that node became negative, they flipped a coin and say, okay, you get radiation to that large area, to the chest wall, to the breast, and all your lymph nodes. Flip a coin, you don't get radiation to the lymph nodes, you just get radiation to the breast. And this data has not been published yet. But what they found was pretty exciting. What they found is that in between those two cohorts, there was no difference in the breast cancer coming back and, importantly, in overall survival. So this was a good trial with over 1,600 patients, majority of those patients, those women being young, about the age of 52. The majority of these patients were HER2 positive, and Dr. DeMonico did talk about this before, but these are women that have a receptor in their breast cancer that is amenable to other types of specific agents. And so, this is exciting data. It's great data. We don't want, as radiation oncologists, we are very hesitant to jump on this bandwagon just yet until we see the actual paper. we really want to know how those triple negative patients did in this study before we start applying this to routinely to practice. And I think that's all I have to speak about today. I wanted to, this is our amazing new cancer center where Dr. DeMonico, myself, and Dr. Siopoli, where we work. It still smells brand new. It's amazing facilities.
Welcome.
Wait, I'm not going to play the video. I forgot that was the video. These are just some highlights of our cancer center here. An amazing group of physicians that I work with. I mean, obviously, including Dr. DeMonico and Dr. Siopoli. We have amazing nurse navigators, cancer center nutritionists that deal with that help with our patients, social workers. We have advanced imaging, and we do have clinical trial options available. This is our amazing, these are my babies, my amazing machines that I use to deliver radiation treatment to, and I'm not going to go into much detail about that. And I also want to put it in a plug. We, at University of Maryland, we do have a proton treatment center. It's not located in Largo. It is located in our Maryland, in Baltimore, near our main campus. I do bring it up because there are select women who would benefit from proton therapy. The type of women that I usually refer for proton therapy or are treated with proton therapy is typically women who are young, have very advanced cancers, needed a lot of chemotherapy for their cancer treatments, and are typically have their cancers on the left side. And so we really want to protect their heart, right? They've already gotten some chemotherapy that may have damaged their heart. Now we're going to give them some radiation treatment, which we can compound that damage. So we really want to protect it. And I think proton therapy is an excellent way to do that. There is a study that just finished accruing a couple of months ago. Basically, women are randomized to either doing proton therapy or photon therapy, and they're trying to see which modality helps decrease the risk of cardiovascular events, like I said, mentioned before, heart attacks, strokes down the road. So that is that's going to take over a decade to get that data. But right now, again, women who are younger, who have more advanced disease with left-sided cancers, proton therapy can be potentially a benefit for them. And I think with that, I am complete.
Well, thank you so much, Dr. Bypass. And there are a couple of questions in the chat for you. I think one you might have already answered, but there's one more. And I know Dr. Siopoli didn't get questions, so I don't know if people have questions for her too.
Is the risk of cardiac events due to radiation in the heart immediate or can occur? So that's a great question. So a lot of the cardiac events that we see typically happens, it could take years to develop. So I'm not going to go into detail the pathophysiology, but we think it's not just radiation to the whole heart, it's actually substructures of the heart that is very important. Especially the coronary artery, the left anterior descending artery is right there underneath the chest wall where we irradiate for the breast cancer. And so we have data to suggest radiation dose to that particular artery is what can drive a lot of these cardiovascular events. And no, it usually doesn't happen immediately. It can take years for those toxicities to develop.
And then one person was asking, I guess, the difference between a mammogram and an MRI.
So I'll take that one. The MRI is a different type of imaging for the breast. It instead of X-ray, it uses a magnet. So your breast goes into a magnetic field. You get an IV dye, and that sort of maps out the breast. It's a great test. It's very sensitive, as we call it, meaning if something is there, it's more likely to catch it than the mammogram. It is an expensive test, and no test is without risks. The main risks of this test is that it may have what we call false positive results, meaning it will show something, something will light up, but and that may lead to more tests and a biopsy, and it may turn out to be nothing. The MRI, we don't use it for everybody. It's not like a general screening test like the mammogram is. We usually use it for patients who are at increased risk for breast cancer, either through their family history or having precancerous cells in their breast, or having a genetic mutation, or have very, very dense breasts where the mammogram is not as useful.
Thank you, Dr. Ciapoli. Does anybody else have a question or two? I know it's after 8:15, so I want to be respectful of everybody's time.
Stephanie, I have a question about a mastectomy versus a lumpectomy. And I don't think that all women who have breast cancer are eligible for the lumpectomy, that they need a mastectomy. So it's not really an option. The lumpectomy isn't always an option for everyone. Is that not correct?
That's correct, but lumpectomy is an option for most women. But you're absolutely correct. Certain tumors are so widely spread out, or the way they grow make patients, women, ineligible for lumpectomy. But again, we have ways to shrink tumors these days with medication. We have advanced techniques where we can take larger tumors out. With certain surgical techniques. So we have been able to offer breast conserving surgery to more women than we did before. But
even
you're
if their
correct.
cancer is a recurrent cancer, even if the cancer is a recurrent
Yes,
cancer.
Then it becomes a little bit, or where did it come back? Is it the same type? What treatment was given before? We used to think that, oh, if you've had cancer before and you had treatment such as, lumpectomy and radiation, you don't have any option but to have a mastectomy. But that's not true anymore. We know that women, if they have repeat breast conserving surgery, so a lumpectomy again for recurrence, they can even be irradiated again. They can have radiation again. So they have more options. So it's not automatically a mastectomy anymore.
Okay, thank you.
Of course.
I think Leslie had a question in the chat. How important do you think it is to get second opinions during each stage of the treatment process? She has not done so for her triple negative diagnosis, but my internist seemed surprised that I hadn't. Thoughts? I'm just gonna briefly say this, and then I'll let Dr. Ciapoli and Dr. DeMonico comment. But I think it's very, very important for you to feel comfortable and trust your cancer team. If at any point you doubt that you're not being heard, you're not advocating for yourself, or if you feel not comfortable with your cancer team, I think, it's always nice. It's always good to have a second opinion or go somewhere else. I encourage my patients to get second opinions all the time if that's something that they want to do. It's a red flag if you go to a physician and they say, no, you shouldn't have a second opinion, because why not, right? But that's my thought on the matter. It's so important to be comfortable, to feel comfortable, and to trust your cancer team.
So number one, I agree. I would never discourage one of my patients from going to get a second opinion. Sometimes I'll even, if they wanted, I might give them the names of some doctors that I think are good in the area. But I would also say another thing. So I had a doctor in training who, maybe was bragging a little bit about medical oncologists, and he said that oncology does the best studies and breast cancer doctors do the studies better than anybody. And that's a little bit, there's the breast cancer being such a high incidence cancer. There's a lot of patients, and there's a lot of patients who are willing, but I'm getting to the question answer. I find myself referring patients for second opinion less often in breast cancer compared to others, because we have really well done studies that guide us for most patients. And so there are times where once in a while, the pathology is a little bit confusing, where I go have someone get a second opinion. But breast cancer, in my opinion, is very different. I saw a patient today that has a very rare skin cancer called Merkel cell carcinoma. And I'm online, I'm on Googling, what are the treatments that we're using? And I found, a team at Hopkins that was doing research, and I sent her there right away at our first meeting. So yes, if you're not comfortable with your team, absolutely go get a second opinion. And, we have such well done studies in breast cancer that sometimes there's not a whole lot of, we know what the right treatment is. We usually have a good idea of what the right treatment is, more so than some of the rarer cancers.
Thanks. Yeah, I mean, I had no doubts about my treatment, really loved my doctor. And it wasn't until the internist a year into my treatment said, "What? You didn't get a second opinion?" that I even kind of got rattled about it. So thanks, that's helpful to hear.
Well, I just want to thank Dr. Ciapoli, Dr. DeMonico, and Dr. Weifhaus so much for being here with us tonight. And you all shared so much like helpful information. And I just personally thought it was so easy to follow everything that you shared too, because sometimes when we do get medical information, there's so many things that are difficult sort of to understand. And you presented in a way that it was just easy to understand and a lot of really, I think, helpful information. And what I got out of this talk, and I know everyone got something out of this talk, is that really that medicine's becoming more efficient. And I know also too more personalized, but I think that there's just a lot of hope in terms of, what is available to people. And that's not that there aren't side effects and things that are super difficult, but I think it's, just it's very hopeful what you presented. And I also just want to share, I'm going to put it in the chat, Hope Connections website and our phone number. And if anybody who isn't already reaching out to us, I hope that you will. We're here to be supportive. And again, thank you everybody for being here tonight. And we will have this recording available. So if you want to watch it again, miss some slides, or if you know somebody who wasn't able to attend tonight, that it will be available.
Thank you
Thank
all.
very much.
Thank
Good
you.
night. Thank you, Stephanie.
Bye, everybody.
Bye.
Bye.